our PD-PAL is able to provide because we are legislatively line item funded. But we do work a lot with, all the cross agencies to work on those waivers and make sure there's access when we can, but it does not affect the services we're able to provide. It does, of course, affect, that transition to hospice and home nursing and all of those other things.
Yeah. And then the wish list that Tony Ann talked about, Massachusetts being different from Connecticut and that the home health agencies aren't licensed by the Department of Public Health in Massachusetts. The hospice agencies, are they the same? Are they not licensed as well? They go by the COPs for Medicare?
I'm not sure. I actually asked Christine if she was able to join because I'm not the hospice expert.
Yeah, I'll check with Christine and get back to this group, but it's a little different licensing process for Connecticut than it is for Massachusetts. So then,
They do follow the COPs. Sorry.
yeah, they follow COPs with no individual state license, right?
They don't go under home health, but they are state licensed.
For hospice.
For hospice, yeah, but not under home health.
All right, so different in that line. And then, it's taking us, God knows how many years to get DPH to update our current regulations. We've been in talks with them for 7 years now. Granted, COVID got in the way, I'll give them that, but it's been 4 years at least that it's been delayed. So trying to, now is the time. So if there is something that we can build into the regulations to promote the hospice providers to do the peds piece, then now would be the time, and we'd have to work quickly to do that. So it might be helpful if we're able to get, I don't know, Tony Ann and Carrie, what you're thinking, but if we're able to get some kind of sample language that, maybe within your program, something that we might be able to work with, so we're not making something up from scratch. Because I think that might be helpful. But historically, it's been palliative can be offered on either side, but we don't have peds programs to begin with. So it's mainly adults, and adults, the aging population, it's usually Medicare. So it falls under home health with the Medicare benefit. So it's difficult to try to figure out that bureaucratic challenge.
Yeah, and you're right. Now, the time is now, right? We have this, what I think is a great platform to be able to, put all these things forward. But I'm kind of new to this landscape. So, you all have been working on things for years and years, and just sitting here with my internal team and batting it around and around and around, it keeps coming back to the same thing. And that is, really what I think we have to, push forward. And I do have, there were some spa options, and we have worked a little bit with our attorney in designing a letter and what it would look like in order to do that. And I can share that with everybody once our attorney looks it over and says, yeah, these are the kind of things that you need to have in your, in your letter or your ask moving forward, and we all know the other things, right? So yes, try and find your pediatric nurse, and, try and, be able to afford your pediatric nurse, things like that. But at the end of the day, you can try for all those things, but we just don't have the opportunity to provide these services the way they're set up, now. So does anyone else have questions for Carrie?
I see
It looks like
Jasmine's got her hand up.
I do, thank you. So can you tell me the name of the program again, please?
For our program, it's called the Pediatric Palliative Care Network, and we're housed in DPH. And then, like I said, the 7 vendor agencies all have their, they're all housed under their own agency.
Okay.
It's on our website. I can send that out.
Thank you. Would you be willing to share any barriers to implementing that program within your state?
in
Right.
the beginning.
Mhm.
We're about to do a retrospective history project to kind of capture all the data because I'm very interested in the process as well. I've been in this position for just under 3 years. I was working on the other side for about 8 years before that. So I've seen a lot of growth within the program, but by the time, I was involved, it had already been implemented. I think some of the barriers still hold true, right? Access, making sure that everybody has coverage across the state. We still have some gaps. So, that vendor model, lends itself to that because it's not a benefit under Medicaid. We rely on the vendor system, so we really have to kind of convince people that it's worth doing this, right? And we know that PD Hospice, PD PAL is not a moneymaker. We do have a funding stream to help them get implemented and keep it going, but the agencies who are doing it are really doing it because they care about the work and the mission. I think in the beginning, and this has shifted over time, the workforce piece was a huge barrier. I mean, just access to pediatrics, to people who are specialized in pediatrics probably was pretty non-existent when this program started. And I think one of the strong suits of this program is that, part of our budgets with these vendor programs every year is a line item for education. And we really have written that in so that we can ensure that the people we're employing are able to have access to advanced training to get up to speed with pediatrics. And over time, we really have created a specialized workforce. Many of our staff on the ground have been with the program for a long time. Once people are educated and willing and able to do this work, they stay for quite a while. So that's encouraging. But those are still barriers. It's always hard hiring. I think just, there's always talk in Massachusetts as well over the years of creating a benefit through our Mass Health system to ensure better access. We ebb and flow with that conversation, the pros and cons of that all the time. I think inevitably we will end up there at some point to make sure that we have, even more coverage than we do now. But we also want to make sure that we don't reduce the integrity of the program that we have created. We've had a lot of flexibility because we've been line item funded in what services we can provide. So it's kind of balancing those needs. Now that the program has, really has a good foothold in the community as well, and parents and families have really come to expect this level of care. And, it's very hard to do that when you're reimbursing for it. So we always worry about losing some of that for families. I think, those are the obvious big barriers that are probably true for all of you as well.
Yeah, that definitely makes sense. And another question, what's your average utilization? Like how many, I guess maybe a year, patients do you have, pediatric patients?
I mean, like I said, many of our families stay on for years at a time, which I think was probably not how this program was intended in the beginning. So this is part of why I'm doing sort of the historical analysis now that I'm in this role. I think we have some work to do on that part of acuity and, making sure that we have enough space in the program to care for the highest acuity patients, and then therefore those who may transition to hospice. All of our families are followed with those disciplines that I mentioned, and they're most often seen at a frequency of a 1-month visit for nursing and once a month for social work. Sometimes there's more when the acuity is up, but we're not providing skilled nursing with this. It's nurse case management through our program. So we're really there to help guide, the palliative decision-making conversations, the bridging from the hospitals, that additional support that families need when they have a seriously ill child. And there was something else, but I forgot.
Thank you.
Sure.
Regina, were you going to ask something?
Yes, I think she answered my question. My question was in regards to staffing as opposed to in terms of nursing care, did they have to undergo any specialized kind of training or things like that? But I think she mentioned it was more of case management.
Yeah, it is case management, but all of our nurses are LNEC trained. I mean, all of our social workers have advanced training for palliative. Even our integrative therapists are all, have advanced certification to be working with. Everybody is, certified to be working with peds, but then in addition to that, end of life care.
How did you
Carrie,
get?
oh, go ahead.
No.
Carrie, I was just going to ask, is every provider that's offering these services also a hospice provider?
Yes, our legislative language states that the contracts have to be fulfilled
They
by
have to be.
hospice. Yeah.
Okay. And then, Tony, and what you were saying before about the potential spa, that would be with Medicaid funding though and federal match. So versus how Massachusetts is
Mhm.
looking at it from a legislative budget line item.
That, and I'm just going to be honest and transparent. That's a good question. I have no idea. I mean,
Well, yeah, it's true. I saw Jasmine shaking her head too, so
yeah, so
yeah. Any
yeah,
spa is a state plan amendment that's usually state funded and some kind of federal
Yeah.
right.
funding as well.
So what would be, I would have to ask you all, what in order to, let's just say we have the wand, the fairy wand, and we are going to make whatever we want happen. What would be, and is there a process to go through to actually be able to provide palliative care under hospice and then bridge over to hospice so that they're not losing their traditional home care if they go on to palliative care?
So I'm gonna take a stab at that. Not that I know based on the pediatric population, but based on the adult population, if somebody is receiving any state-funded services through waivers, say the Connecticut Home Care Program for Elders or anything where they're getting state funding already, they have a care plan, and that care plan has a max dollar amount per month. So if they were to receive extra services, palliative, or eventually transition to hospice, they've always needed to keep it, and it's funded by Medicaid, I should say, and it's funded by Medicaid. Then they need to keep that care plan dollar for the support services in line with the cap, including the palliative or the hospice services. So if it's $7,000 a month and they're getting $6,000 of state funded home care support, they can only have $1,000. I'm just throwing numbers out there. They can only have $1,000 of palliative, or they would have to balance that and cut back. That's how it works currently. Under any state funded case, you can't go over. I mean, you could if it's a special situation. I don't know if Jasmine and Regina would be offering authorization special for that. I know it's been a case by case in the past where it might be an option, but usually you have to stay within the cap for the spending cap for the month for that particular client.
So I'm not sure about the details of that. I do know that we have policies and they're written as guidance. And we also have our medical necessity kinds of like clause that I told you guys about, where we're always willing to review any cases to see if there's more we can do to help, or if this service or equipment or whatever it is, benefit under Medicaid is medically necessary for each member. So I'm not sure about the caps, but
Using that experience based on how it works for the waivers. So I'm assuming if there's any state funding in line, it's, there's got to be authorizations in place, and then, you'd work at it that way.
Yeah, well, yeah, and then there'll be a thin line between going over that. For example, like with maybe spa language and other areas where we may pay a per diem rate, um, we can't, it's a very fine line between going over that, and we could, risk some pushback from the feds so yeah.
I just have one other question too, because putting my imaging hat on for a second, because that's where, I spent most of my career, and it used to drive me crazy how insurances wouldn't pay for, let's say, lung cancer screening of the chest. They won't pay for that, but yet they'll get hit with radiation therapy once there's lung cancer. And, it's like, it's how you kind of even that. When are we going to spend the money? And my question is, and maybe this is way off, I would think, knowing hospice service and what we provide under hospice compared to the once a month or twice a month visit by a nurse for palliative care, I would think would be less expensive to be able to provide palliative care, and they still have home care, than even in what we get paid when we have hospice coming in and they still have home care. Am I off on that, or?
So are you saying that ultimately it would be less to continue home care services and add on palliative than to go to hospice?
Yes.
I'm not really sure. It would definitely be interesting to see what that data looks like. But as Carrie pretty much said, I mean, people can be on palliative for years, whereas hospice is supposed to be for 6 months. So given that, and then obviously, right, there'll be outliers. The services are similar, but they are different in terms of the length of time. With hospice, all other treatments that are like treating the terminal illnesses, those stop. So I think I sent out an email, but that's pretty much what it is. Like most of the time, all of the hospice services are covered. There's not typically a need for a prior authorization, so it's an ease to go from skilled nursing to hospice. I think palliative is a gray area, but it's a really important one. It's definitely a gray area, because we don't know how long someone will be on palliative for, and if they'll choose to still treat certain conditions. I've been seeing that a lot lately as a provider, getting people who are on hospice, but they're still being treated for everything. So it becomes confusing, but it's different, and I'm open to it as a provider. But for Medicaid purposes, it's something we have to explore and really look into. And I'll be really interested in seeing what data Carrie comes out with from her retrospective study.
And not to, like, we have had kids on hospice longer than 6 months. I mean, obviously you do your face-to-faces and whatever, but with concurrent care, it's the doctor can still certify, because if the disease ran its natural course, yes, this child will be dead in 6 months, but it's not running its natural course because of concurrent care. So we have them on, and they get re-signed up for hospice because of, concurrent care. So that would be an interest, like, how much does it cost to have your average child on palliative care with home care compared to having them on hospice and home care? Like, I think that would be interesting, because it really could be providing palliative care and home care could be even less than hospice and home care until they're really ready for hospice and we pull that trigger. It actually might be savings of money. So that would be an interesting thing to look at.
I think the challenge is going to lie in using data in our state is not representative of the services people are getting, because we've been forced to utilize whatever name I'm given, right? And, hospice should be a philosophy reserved for those who are really moving towards their end of life and not not someone that's looking to maintain all the things that concurrent care lets you, but I really I want families to choose hospice when they're ready to focus on the end of life journey and how we get to that point. I don't want families to choose hospice because it's the one service I can get in their home and they can still get their chemo and do everything else. So I feel like our data Tony, and I think that's an incredibly important question. I would not use the review of our state to ascertain that information because I think I have patients receiving hospice care that are being billed as palliative by virtue of the constraints of the home care agency and vice versa, right? So, right, if a place doesn't do hospice, but they do palliative, but they're really doing end of life care for these patients, it's going to be billed under palliative is the only way they're going to get reimbursement. And so your data, Carrie, would probably be a little bit more relevant and helpful.
Yeah, we do have, yeah, I mean, I had raised my hand a while ago because I was going to bring up, concurrent care as well. And I think just thinking about the cost savings, I'm not working in that same system that you all are with reimbursement, but I do think that, I think even with this conversation, we have to also realize that, a pediatric hospice patient is taking up a lot more time, resources, money, no matter what, no matter where they are in their illness journey. And so I think that is, just thinking about regulation, even here in Massachusetts, one of the points that I was curious to talk to you all about, we don't have regulation here either on pediatric hospice, really. Like, there are many, many agencies who just refuse to treat pediatric patients in our state. And those that do, the ones that we contract with, obviously all will care for family through hospice as well. The reimbursement for that is just, pediatrics are not little adults. Like, it's just a very different process. And I think we, somehow on the national level really need to start having that conversation, because until we do, hospices are just going to keep saying no to pediatric patients. They take too much time. There's not an expertise there within their staff and workforce. I think it's a bigger problem still within hospice in general. And, I think our program was really started to help bridge that gap for families. And of course, it was started right before concurrent care, a couple of years before. So that really kind of threw things as well.
Yeah.
And we do have some data about hospice utilization for families who are involved in the PPCN. But there are still certainly many, many cases who just never sign on to hospice.
Carrie, this is Brian, and I was wondering, and I apologize if you mentioned it, but how much is your line item?
Right, currently we're just under 10 million.
Just under 10. Okay, and so that provides for the net contracting with the providers, but you also mentioned it does education for providers as well.
That's all part of their budgets. Yeah.
Okay, so that's part of their budget. So it's just under 10 million, and it's servicing you have 700 patients now currently.
Yeah, we usually serve about 730 throughout the year, with those who come off or those who die.
Okay.
Can I ask how much of that funding is how much is reimbursed by health insurance versus the state budget?
Nothing.
Okay, on the website it says if you're when I read your website in preparation to chat with you today, my love, it said something about costs will be incurred or provided at no cost to eligible children and their families if these services are not already covered by their health care plan. So I just don't know.
So if there are billable services that the agency can bill elsewhere, they are required to do that first. But the services that we provide are not really provided anywhere else or covered by anybody else. So we have that language in to differentiate between hospice and other services that are already in place, home nursing, et cetera.
And as we're appealing to I'm sorry, Jasmine, I see your hand, as we're appealing to the sensibility of our legislators? Is this a budget that's grown in time, or is this a budget? Are we going up or down in our, just for context?
We always have, I don't think we've had a few years that were flat. We've never had a year that's gone down. The budget has grown significantly with the support of, a lot of family advocates. And
I believe it started in 2006 at around, it could have been, I want to say like $850,000.
good memory. I think you're right around there. Yes.
Sorry, Jasmine, you had your hand raised. I apologize.
No, it's okay. I'm wondering, so that's a lot of funds. So I'm wondering if at any point you guys plan on exploring maybe like 1115 waiver, a way that it could be reimbursable.
Yes.
Is that going to be in the study as well?
Not this study. There has been other, Mass Health is looking into this right now. They have at various times throughout this, 13 years of this program have proposed coverage or a benefit. There is some energy behind it right now, and I do expect that will hold at some point in the pretty near future. And the idea right now would be to create it as a braided funding so that they cover, the pieces that Mass Health is able to cover, and then we're still able to use the rest of our budget to supplement with the things that are not going to be covered by insurance. So it won't replace us, hopefully. I mean, that's the goal.
Yeah.
Gracie?
Yeah, Carrie, I'm curious what the feedback from the providers have been. You talk about the budget has grown, but what has the feedback been regarding how much money they do get to care for these cases? Do they feel that it's enough to pay for their specialty staff for the education, or are they belly aching about the reimbursement?
We've really worked with agencies to make sure that any overhead costs are covered, and the requirements that we're asking, we're supporting through our budget. Really, the way that it's worked is as we've increased, we've received proposals from our agencies to say, okay, with additional funds, we can take on X amount of additional patients. And this is a good time to mention, while we're covering around 700 families right now, we still have a wait list of about 150.
Oh.
And we still have, a few towns across the state that have no coverage. So, I think the growth has really come from those numbers, like knowing that there are still families who are eligible, but because we don't have a benefit, we're not able to 100% cover. That's why we're really trying to work with Mass Health now to create that braided funding benefit so that we can provide more coverage to anybody who qualifies.
The wait list I feel like is something that's come up more recently. Like in working with Bay State and other places, I feel like the wait list of numbers and needs has grown over the last couple of years. Is that a fair?
I don't think so. I think, I think they've always had some wait lists because we're really dependent on the funding, right? We can't just bill to whatever services we need. I think as our census numbers have grown, as our teams have grown, as our reach has grown, so have our wait list numbers. And it ebbs and flows, of course. A lot of it over the last few years, during COVID with a workforce shortage, a lot of our wait list was, is a fallout of that, just not having enough staff to grow the census, even if we had the funds. But we're kind of past that hump now. And the last 2 years, the wait list has been going down, but we're also getting more referrals. So, it kind of always evens out. And I mean, to that point, like I'm thinking a lot about, eligibility and acuity and creating some measures to make sure that, we're prioritizing those wait lists appropriately.
I think that makes good sense.
Yeah.
Make sure you're kind of keeping an eye on the controls of the program.
Yeah.
So I have what, so this program has gone out, I guess, and has asked hospices that want to be involved
Mhm.
And then the hospice will get referrals for palliative. And I'm not sure if I heard this correct, or do they have a license to do palliative care? Like, in other words, they have, no, because they're not.
I don't think they I don't think they do. I don't think they have needed to in the recent years. I know there's some adult palliative programs that are coming out of our programs as well, not PDPAL, but our agencies. And they're working through, an entirely different system. So no, I don't think there's a requirement for that. There is not. We do require that if they have a contract with us for PDPAL, that they are able to cover that patient for pediatric hospice. And I think that was really a lot of the early ideas of why this program was created. Again, to bridge that for families, but also to try to support that workforce and that expertise and familiarity.
And if a hospice is in the home for the pediatrics under palliative care, that patient is still receiving their home care?
If it was already in place through concurrent care, they should be able to still receive their home nursing. Yep. Which is a completely separate program from either of us, but yes.
Right.
Yeah.
Okay.
I mean, we do have many cases, as I'm sure you all do as well, like an oncology patient, for example, who didn't have nursing in place. Those cases are really hard when, health declines and they really really need more nursing support, more than a hospice is able to provide. So.
Well, our bigger issue, Carrie, is having kids that need hospice support for the philosophy of end of life and guidance, but can't have both that and their home care nursing, where they, even with concurrent care, have to choose between one or the other. And that's probably, for me, the hardest issue with the two together, is when you have to have a family choose. Do we stay with the nurses we know and know us, who are really good at the vent, or do we go with the team that's going to help us with symptom management at the end of life?
Yeah, it's an impossible choice.
But and this is where I'm struggling again, and I hate to sound like a broken record, because sometimes it takes me a while to absorb it. But I'm being told by my pediatric nurse that when we have patients on hospice, they're still getting their home care. They're still getting their skilled nursing. They're still getting nurses on a home care, from a home care agency, as long as it's not the same agency that's providing the hospice, they can still get their home care.
Are you referring to your shift nursing, right? Where we're discussing shift nursing services? Like their hour shifts?
Yes.
So it's only if they co-vendor, right? We have a lot of cases that don't co-vendor for us currently in the state. And so it's only if you can have a co-vendor agreement do we get both in the home. So there's many cases where, Tony, and we have not been able to get a hospice agency or palliative care agency or like-minded agency to come in with the shift nursing agency. That has been one of our greatest limitations when it comes to direction of care for end of life for children at home.
Okay.
So what we've done in cases, and it's different pockets of the state, is I've coached home care shift nurses how to do it, or we've switched depending on what the needs are. The description of not having shift nursing in the oncology population is met with the desire for more shift nursing from hospice, which we know we don't get. We do find we have so few dedicated pediatric hospice providers that they find themselves providing by default shift because they come and they stay and they're so good at doing it. But obviously that's not a sustainable model for the state.
Yep.
I noticed, Carrie, that most of your states most towns have a listed coverage point. How did you come to how did you get that map covered? Because we have pockets that are, we have some towns that maybe overlap, like some agencies that might overlap. How did you figure out how you were going to cover your state with your 7 groups?
Yeah, it's really just been on a case by case rolling basis. We review the coverage map every 2 years or so and make sure that it's still working for people for those where their catchment does overlap or butt up against each other. And, in many cases, some of these agencies have grown out of, doing the work because they want to do the work. So most of these agencies started with a much smaller catchment area and would slowly take on new towns as the needs arose in the early years of the program, especially. But that still happens now when there's a child in an area that is not covered. Our PD-PAL team will go and advocate with their hospice. And if they're willing to take that on as a hospice catchment as well, then they will add that town. But we do review it. It's been pretty static for quite a while. We did a little bit of reshifting this year because one of our programs was growing. But yeah, it's really just been kind of an organic growth there, program by program. Also, we previously had a few other programs that closed. And so as those closed, other of our stronger programs were able to absorb some of those towns.
Can someone, and I'm not going to just yell out Jasmine because I don't know that it is Jasmine, but can someone, and maybe Tracy, because I'm actually have pulled up on my phone the whiteboard that we kind of have put together here, the internal team, and I'm trying to read the things that we have on it that they have found that hospice. And I have to look into the co-vendoring thing too, because we've done it where we've had kids on hospice and they have their home care. And I know in one instance, probably about 3 or 4 months ago, they had shift nursing. I don't know if it's a case by case that they look at, but from a Medicaid perspective, is a child who's on hospice allowed to have home care in the home, including shift nursing? And if it's palliative care, do they then lose their shift nursing? Because I feel like maybe we here at regional are functioning under the wrong idea. And I just need that really confirmed for me, because then, this may have to go a whole different direction.
I can find the answer out regarding the shift nursing and hospice.
Okay.
By checking in with those providers that offer the shift nursing and what their historical experience has been. But I sense that the answer to your question about shift nursing and pally is no, because it's not a recognized specialty and it's not reimbursed as a recognized specialty. So if you're already getting shift nursing, that nurse should be providing the palliative care, is I think how it would be interpreted.
Okay.
Even though it's not a specialty of that nurse.
Right.
So I think that's how it would be interpreted, but I will see what I can find out.
Okay. Yeah, that would be great, because these are the things we have to attack, right? I don't know how else to do it, but think about the things that right now work against us my whole thing with palliative care that, that I've been told is, well, you have to provide home care. And I don't want to provide traditional home care. Johnny broke his wrist and now we're going in the home and we're making sure he has, all the therapy he needs and whatever. I would do it if I could limit, right, the home care you would provide. But I would only want to do it for pediatrics. I don't want to do adult home care. So, these are the things too, like, can you do it this way? Can you just sign up for pediatric, critical care, or complex care, home care, and not have to do adult at all? And I guess you can, because one is Medicaid and one is Medicare. I mean, I know we would have to be under Medicare in order to get paid by Medicaid for that. But just things I'm trying to like toss around in my head to try and figure out. Like right now, when we think about all the kids that are probably in need in the state of Connecticut, granted, we don't go everywhere. And again, I say it all the time. Right now, I have 5 kids on census. Like, and when you think about your program, if we were able to do it through palliative care, right? And I would even be willing, I mean, we definitely would need help with some funding, but I'm providing less care through palliative care than I am through hospice. Just the things that keep me up at night, right? That
I'm going to check internally on the questions you asked about see what I can find as well about whether or not the child would lose their home care services with hospice and with palliative. Or my thoughts are similar to what Tracy said, but I want to confirm. Not sure if it's even covered palliative, but I'm going to check.
Okay, great. Thank you so much. And does anybody have any other questions for Carrie? We're hitting about an hour.
That went by fast.
I know. Time flies when you're having fun.
I do think Christine McMichael would probably have more information for you all too about the hospice regulation piece. So hopefully you guys can connect with her too.
Yeah, Christina will have the anecdotal pieces too from the provider perspective. So
Yep. She's been around the whole time. So she's a great resource.
If you want me to see if she can join us, I can ask that, Tony Ann. I don't know when you're meeting next.
Yeah, I think our next meeting is the same time around in December, I think.
Well, just get that to me if you would. And then the other question, because it's a completely different program, is that California program that's Medi-Cal. So it is Medicaid funded. So I don't know if you want me to continue to pursue having somebody from there present.
I mean, what do you think, Carrie? I think, Carrie Moss. I mean, the more knowledge we have and understanding, I think would be great.
I do too, because I think that the greatest disparity here is the funding. 0 to 10 million.
Absolutely.
It's a pretty disparate difference. And so I think that knowing all this information really help us request the funding that is really ultimately what separates what we can do, right? I know some of the providers, Emma and such, that do this work in Massachusetts, and it's not an option that we have right now.
I know. I always, when meeting with other states, it's always, I want to meet. And I also know that like our model is so different right now that it is not always the most helpful or transferable. If you do have people from California come, I would love to join as well to just listen. Because, as I said, Mass Health is looking at a benefit for our state as well. So I would love to, just listen in.
Absolutely.
All right, well, Tony Ann, let me know the date as soon as you can, and then I'll do the outreach to both Christine and my colleague in California and try to get both of them.
I can't find do you have the date off the top of your head?
Are you asking me?
No, Peter.
Can you say that again?
Do you have the date for our next meeting at your fingertips?
The full working group or just the subgroup?
Just the subgroup.
Yeah, I don't have that at the top of my fingertips. I apologize.
Yeah, I think we're gonna probably make, and Kerry, this is with your agreement, that we make the next meeting still yet again another subgroup.
I would think so.
Pulling in everybody again. So what, can we do that, Peter, make the next meeting a subgroup meeting, and then what would that date be?
Yeah, you can do that. It'd be up to you guys. So whenever you guys want to schedule the next meeting.
Yeah, I don't have another large group meeting on my calendar, I don't think. I'm looking quickly on my phone, no less.
See. All right, well, we'll get that, we'll get the date out to you, but just know it's probably in 4 weeks. Or maybe somewhere, well, now I just, let me do this. Where's my calendar? No, we don't have one. All right, we don't have one on there. All right, we're gonna have to set that. I'll speak to Kerry offline and we'll get some date out there. But that, I mean, that would be great if they could do that. And then Jasmine, if you could get back to us with what you're gonna look into, and Tracy, same thing. And then we'll just, maybe we could just share information through email before we even meet next time, if everybody gathers it before then.
Yeah, but my only constraint is that I don't want to reach out to Christine and Sheila in California unless I have a meeting date that I can actually throw out there to them. Because they're
Okay.
gonna, especially as we're approaching holidays, they're gonna need to have that. So that's why if you and Carrie can get together and throw me a date, that would be helpful. If it's the 11th, it's gonna be tough for me.
How about if it was going to be the 10th? And Kerry, does that work for you? And can everybody on here do the 10th?
I have a meeting.
Oh, Tracy, you and those meetings.
Yeah, I'm sorry. Well, I just committed to my nephew today to take care of his son on the 11th. So I can't back out of that one unless you do it a little earlier. I could do the 11th, but I know that might be a problem for Carrie.
Are we speaking of December?
Yeah.
We are. I can do the afternoon. I can't do the morning on the 11th.
Would you do a 2:30 on the 11th?
I could do a
Versus-
2:30 on the 11th.
Okay.
The 11th.
How's everybody else on the 11th?
I
I'm
can do
okay.
afternoon. Yeah, I can do the afternoon.
Okay. Then how about we do that December 11th at 2:30?
Yeah.
Okay.
Peter, maybe you can send out a meeting invite right away so we get that on our calendars.
So can you guys just give me the date and the time just so I can have it?
Sure, December 11th, Wednesday at 2:30.
All right, I'll send that out right after this meeting.
Okay, thank you. Okay. All right, anything else to go over? Dr. Moss, do you have anything you want to go over? Are we good to adjourn?
I just want to say thank you to Carrie for coming. It was really nice to see you again. And nice to see you continuing to do great things. So always a privilege.
Thank
And
you
it was
for
really helpful contextualing. This is really helpful. I bring a very different skill set than many of the people on this call. As you know, we work together. I'm very clinically minded. So I like to ask the big money questions, but ultimately it's the big money that's preventing us from doing what we would like to do here in Connecticut. So
That's the reality for sure.
Empower me to ask for the big money.
Yep.
Yeah.
I know, we all just
And
wanna do
Carrie,
Yeah.
please join us next meeting if you want to,
I
listen.
would love to. Yeah, please send me the invite. It was nice to see you all.
Okay.
Thanks for having me.
Take care,
Okay.
everyone.
Thank you all.
Bye.